we actually got the biopsy results faster than we thought we would get. Are you recording? Is that okay to record?
It's okay as long as you get permission. So in the future, if you ask the doctor,
that's fine. Yes. So we did get the biopsy results early, like the preliminary biopsy results that we mentioned, that unfortunately do show neuroblastoma, which I know we were kind of expecting, but still hard news to give. Based off of that, do you have questions before I move on?
Like, is she like in danger, or is this like a known procedure that's pretty successful?
Yeah, so we're pretty good at treating neuroblastoma, that's for sure. There's a lot that's still unknown.
Yeah.
Kind of, as I mentioned on Sunday, we can get a diagnosis pretty quickly, but then we have to know a little bit more about certain characteristics of it.
Yeah.
And so we do other stains and send the tissue off to kind of tell, are we in this intermediate risk category? Are we something that might be a little more aggressive that requires different treatment?
Yeah.
And so putting together the whole clinical picture, her age when she was diagnosed, the way it's looking on the preliminary scans we think and hope most likely it's going to be in that intermediate risk category, but we can't say for sure until we get that additional info from the biopsy. So we will let you know, obviously, as soon as we have that info, because it will dictate our treatment. That being said, that does take quite a bit to come back. So it can take up to 2 weeks even to get that information. But obviously, we might not want to wait a full 2 weeks to start treatment.
Yeah.
So Dr. Paul and I were kind of talking about options and what would be the best and safest course of action from here, leaning towards the possibility of starting treatment, just because we know, it's kind of close to her spine. It's in some areas where it's not causing issues now, but if it grows anymore, it potentially could. So probably the safest thing would be to start treatment as if she's in that intermediate risk category.
Yeah.
And then if we do get info that we have to say, all right, we're switching the plan, we're switching up the chemo, then we could do that from there. Does that all sound okay to you so far?
So
you start shrinking the tumor first.
Mm-hmm. So we know it's for sure neuroblastoma. Yep. And the goal would be to shrink the tumor, to shrink the cancer. And then you would ask me on Sunday, is there surgery, or what are the other kind of modalities for treatment that we use? So we would look to shrink it first, for sure, with chemo, and then hopefully try to go in and, surgically take out what is left. So that would depend on how her imaging looks after starting treatment, I should say. So we kind of see how it's responding and
so how
plan
long
surgery.
how many chemo rounds would you do before you do like another MRI or CT or whatever?
I know in terms of if it were kind of that like lowest intermediate category that we would expect, the whole course of chemo would be like at least 4 months or so. So imaging at some point in between there to kind of see where we're at.
Is that 2 or 3 days out of every 2 weeks for 4 months?
Of when she would be inpatient getting chemo? Do you know off the top of your head, Dr. Paul?
I can get the specifics once we know a little bit more. I would mentally plan on like 1 week is sort of chemo week where you're here mostly, and then the rest of it you would be recovering at home.
For like,
and that would be
like week on, week off.
It's probably more like 2 or 3 weeks off in between.
Okay, so each round's about a month and one.
Like
I would say for like
3 to 4
ballpark,
weeks.
that's fair to say.
Okay.
Yeah.
Okay. So that'd be like 4 rounds then. 4 months would be like 4 treatments.
Potentially, yes.
Okay.
There's always the possibility that we do have to add on additional cycles or change up the duration of the cycles and the treatment plan. Yeah.
Some of these are really chemo responsive and they shrink really quickly, and some don't shrink as fast. So the length of treatment to some degree depends on how quickly it shrinks.
Okay.
Hers has a lot of calcium in it, like we mentioned, that's not going to disappear with chemotherapy, and so we'll have to factor that into with how much we think like the actual tumor part of it is shrinking versus the calcium that's just going to kind of probably contract down and still be there.
Okay.
But that calcium will be removed with surgery at some point.
Exactly. And the calcium itself won't cause her harm, but we'll still take it out because it just doesn't belong there.
Yeah. So, how long do you think this has been growing? Do you have any way of knowing that?
I know our good idea is that it's been growing at least since that first time that she was diagnosed with pneumonia.
Okay.
Because there was something seen on the chest X-ray that looks kind of similar, so it probably started growing a little bit before that.
But not too long before that.
It's always hard to say.
I would say she probably wasn't born with it, but she probably had like microscopic starts of it very early on in her life. And we know that neuroblastoma is a disease of super, super young kids, like some kids are born with it.
Mhm.
It's probably been months that it's been growing. The x-ray from a month and a half ago to the one that you did before this admission
Yeah.
doesn't look that different. So at least from that kind of limited view, it's not looking like it's growing super duper quickly.
Okay.
But
'Cause over 6
it,
weeks it didn't change a lot from like that front x-ray view.
so,
might have
and
grown
it's a
quickly and
large
stable.
tumor now.
It's
So it
pretty
must have
large
been
now.
growing for quite a long time to
So I
get to
think
that.
it's been over months, and kids are so adaptable.
Mhm.
They can just live with very large masses with no symptoms whatsoever.
Yeah.
And I think it was really only when an infection probably got stuck behind the obstruction of the mass that there was any sign. So in a way, that pneumonia kind of brought her to medical attention probably faster
Yeah.
than if it had been so large to kind of cause symptoms
Yeah.
just on its own, which is good for her.
And that's one of the things I was mentioning to Fernanda on Saturday is that there is absolutely no way that you guys could have picked up on this.
Yeah.
So it's not like you all waited too long or that you missed something because she wasn't showing any signs or symptoms. of
Yeah.
this.
Even when you listen to her lungs, they sound pretty normal.
Yeah.
Because it's not in the lung exactly, so the lung around it sounds normal. The air is moving
Yeah.
around. It's very sneaky. I mean, who would expect, right? Like with her
Yeah.
bouncing up and down and everything.
So there are a couple other things that we think about now. So obviously we've gotten these images of her body to kind of help us stage and see how big is it, where is it, critical structures. We also have another kind of imaging study that's specifically for neuroblastoma called an MIBG. If you've ever heard of like a PET scan, they're kind of in that same family where it's a little more specific to neuroblastoma cells, and it'll tell us kind of where it lives in the body and pick up on it a little bit better than some of the other images that we have.
So
Yeah.
what would we be doing? Like, would that be like something we do before starting treatment, or like?
Most likely, I think it depends on when it gets scheduled. Usually,
I'm hoping it'll happen next week, but
Yeah.
it takes a little bit of time to organize.
Mhm.
Okay.
We wouldn't wait to start chemo if we needed to, and that was taking a couple days.
Yeah.
It just needs to be done very early in the.
But like chemo being in the body doesn't like affect.
If
those tests.
chemo works great, but it doesn't work so quickly
Mhm.
that it would make that scan hard to interpret.
Okay.
And you're talking about the
MIBG, exactly.
BG.
So in an ideal world, we'll get you home hopefully tomorrow because we'll have this scan. She'll recover from anesthesia and then hopefully get you out the door tomorrow.
Oh, cool.
As we're waiting for that final information about how high risk is this, what's the exact composition of the
Yeah.
tumor itself, we would get the MIBG scan, which will happen outpatient, and that will also be under anesthesia. And there are a couple other things to do. So in terms of just kind of the checklist, I know we got an echo on her, but it wasn't great in terms of her heart function. And her heart was fine, but the echo itself was a little
Yeah.
bit hard to get. So next time she's under sedation, we probably want to get another echo.
Okay.
I know you guys had talked a little bit about line placement, and you guys had used the word port. Obviously, we have to kind of coordinate what line it would be. There are, if she ends up having one of those higher risk neuroblastomas, she might need a different kind of line.
Yeah.
And I always like to say, better to kind of cross that bridge when we come to it as opposed to tell you all the possibilities, because sometimes I think that's just overwhelming to go
Yeah.
over all the ifs. So just know that we'll let you know about the kind of line as we kind of get to that point. I think
And
there
the
was a
surgeons
caveat.
you met yesterday would be the ones to do it, whatever it ends up being, and so they're already part of her care team, and
Okay.
that decision can be made kind of right before it's time to do it.
Mhm. Yeah.
So I wouldn't stress about the specifics of that.
I don't know why you would stress about the specifics of that in the first place.
I don't know. I'm just doing whatever the doctors say is
Oh,
best thing to
because
do.
I just thought they just picked the port, they put it in, and
So if it ends up being that intermediate risk neuroblastoma, then the port definitely is the right move. If it is higher risk, then we might need a different kind of line just because the treatment looks different.
oh, I see.
Yeah. And then another thing that we need for diagnostic purposes is to get a sample of her bone marrow. I'm not sure if you remember any of your bone marrow biopsy procedures, but it's the exact same thing that we do for children who we are evaluating for leukemia. And so that would also be under sedation, under anesthesia. And so she won't feel that at all. And that's something that's not as urgent, but we will do that coordinated with another anesthesia event, so we're not putting her under just for that.
Okay.
We would try to coordinate that.
Good.
The only difference is we do both hips, so she would have two Band-Aids after she comes back from the procedure.
Yeah. I don't remember that being too
For
Uh,
leukemia, we
afterwards.
only do one side.
right, but
for-
I don't even think it was that
yeah.
Gotcha,
critical.
Yeah. So it's the same
for
thing,
him.
but instead of one,
Yeah. Okay.
It always looks
Yeah.
like a
And the
really big
reason for
Band-Aid.
that,
And the reason for that, so sometimes neuroblastoma cells can be in the bone marrow itself. So we just have to check, and the reason we do both is because we want to make sure if it's hiding on one side or not the other, that we're not missing that by just doing one side.
Okay.
So we're looking for neuroblastoma cells in the bone marrow.
and so that's to prevent or to check for metastasis.
To kind of evaluate what treatment plan we should be giving. Because if it's in the marrow, obviously we know it's it's elsewhere. It's not just in that one solid tumor.
She's doing it from sitting now. She's practicing
She's going
standing
fast
up.
there.
Um, Let me see. I had a question. If you have a question,
We're not
ask
going
it.
anywhere. If you think of more questions, we can always go over
No,
them.
I mean,
later
it sounds
here tomorrow.
fairly
Yeah.
straightforward.
When do you see chemo starting?
What do you think, Dr. Paul, for the start date?
If the MRI doesn't show that there's sort of urgent stressor on the spinal cord,
Mhm.
I think how well she looks, we could probably do the MIBG in the bone marrow and get the central line in. And if we can wait long enough to get that last test on the tumor and know if it's the intermediate or the high risk, then that would probably take 2 to 3 weeks. That would probably be the most organized way to do it, but if she has any sign that she needs more urgent care than that, then we could move that timeline around.
And what would be the earliest, do you think?
The earliest, it would just depend on if she develops symptoms. So as of now, we know that her tumor isn't really affecting her breathing. It's not affecting her spinal cord. So if she were to start to, get a little bit weak or not, have the strength in her legs or her arms that she does now, or anything that's asymmetrical, like using one side better than the other. It's a little bit harder in a kid this age who's not potty trained, but in an older kid, if they're having incontinence, those are all signs that the spinal cord is involved. So it would be that or any signs of changes in her breathing.
Yeah.
Okay.
I mean, if she's
I guess-
really
So
in
that'd be
like risk of something going
Yeah.
Yeah, my
wrong if we didn't start, I mean, I could theoretically start today if I absolutely had to. I just don't think that's in her best interest.
right. No, I'm just wondering if today you see that it's dangerously close to her spine.
Then we would
When would it start?
probably put a line in her and start.
Probably next week
Yeah.
if we can.
Okay.
I would probably want to start a little bit of steroids because it can help with swelling while we wait for getting a central line and things. Because I
Gotcha.
definitely can't give her chemotherapy through a little IV. We would have to have
Right.
a better
Yeah.
We could do like a PICC line if we needed something super quickly. You don't want to do that? Okay. But I just, having met lots of children who just got diagnosed with neuroblastoma, she just is not someone that gives me that feeling that we're going to have to really rush things because she's not ill appearing, which some kids are when we first meet them because there's a lot of
'Cause-
tumor and it's causing stress on the body. She's obviously got great strength in her lower body, which means the spine is doing everything it needs to do. The labs look fairly normal, really normal. So, not giving me any signs right now
Yeah.
that we're going to have to rush along.
Good.
Um,
Okay.
so I think it's probably best for everyone, including her, to kind of have her be at home while we wait for some of this testing. But just knowing that we can pull the trigger to do things faster if there's ever a sign that that's what we need to do.
So probably somewhere between 2 to 3 weeks if we do it like the proper, more organized way. Okay.
But we know in our world sometimes we make plans and things change that we have to move in a different direction, and do it faster. So we're always prepared to do that if we have to.
Okay.
And we'll have a much more organized conversation about treatment too once we have the exact, like these are the medicines on these days and all of that. We'll outline once we are able to do that.
And like when she's doing chemo, like so that will be like a week in the hospital each time, followed by 3 weeks or so.
It's probably a little less than a week, but
Okay.
that would be rounding up a little bit what I would expect.
Okay.
That's what I would plan for, because then if there's any reason to stay a couple extra days, you could do that.
Okay.
And that's assuming it's sort of this intermediate risk, which is what I think it's going to be. The other thing we'll probably talk to you guys about tomorrow is maybe doing some signing of research consents for sending additional testing. I have to make sure she's kind of in the right category to even get that process started. Because she is so strong right now. The other thing that I spoke with the pathologist about is we got a bunch of little core biopsies from that
Are you good?
Daddy. Oh.
Love bug. What happened? Yeah, that's all part of learning to walk, my love. I know.
What part of you was that?
Yeah, I think that was her forehead.
Here, I can help you with the bug. You want me to
I know.
help you?
Daddy? I know.
Pull it up and then down. Monica just bumped her head.
Daddy makes it all better.
It's a quick recovery though.
Yeah. Yeah.
Oh, your attention's back over there, huh? Feeling good? I'll finish my thought. Does that sound okay?
Yes.
Okay, I was like, I think we're okay. So the pathologist was saying, we have a lot of tissue. We can definitely make the diagnosis. We can get the things we need to like do the risk stratification, but we are kind of more and more wanting more tissue to send off genetic testing on the tumor itself to kind of be the most informed about our treatment. We may have less tissue than we would need to kind of do the full panel. And so one of the things we could consider to get around that would be to do not a big surgery, but more of an open biopsy during like a central line placement or something. Her mass is so close to the surface in the front that's why it was so easy for them to biopsy, that they could probably get a very easy biopsy as well. It would just be like, instead of a tiny little poke, would have a little scar. So I'll talk to the surgeons about that. I don't know enough about what they'll get from those first biopsies to be able to say for sure, but I just don't want to surprise you with the possibility of that surgery as well. And that's really just to make sure that we get all the information before we were to start treatment. And the surgeons that would put the line in would also do that. So that would be pretty easy to coordinate. It would be the same procedure. And the recovery from that shouldn't be, might be more sore from that than from yesterday, which she's acting like didn't even happen. But it would still be a pretty minor procedure. And that's just because we're knowing more and more, like, the more we understand about genetic testing, the more things we want to test for, but you need tissue to do that. So we get more and more asked to get lots of tissue. But it's pretty easy to get to. It's not hidden deep in the body, but we can't get to it. So that's another thing we'll consider. Short term, she looks so good.
Yeah.
We just want to make sure her spine is in an okay spot. I talked to the surgeons yesterday. We all agree that doing chemo first is absolutely the right move. We know neuroblastoma does shrink really nicely in response to chemotherapy. So once we get started, it should work very quickly.
Yeah, and then I guess probably we start prepping for the MRI at like 3:30 or something.
I hope so. The nurse will come in once they get like a real transportation time. Should be pretty easy prep. If she's feeling pretty, probably just walk her down.
Yeah.
So I think taking it day to day makes a lot of sense. You guys feel comfortable with the concept of going home while you're waiting for things?
Yeah, I mean, she doesn't seem, as long as we know what to look for, she doesn't seem, like she necessarily needs to stay in the hospital for a week.
I think it might be hard to keep her fully entertained for that time.
Yeah.
You're gonna be walking when you come back.
Yeah.
Yeah, I think so.
And that's a great sign. The fact that we're like, mostly worried about your ability to keep her happy and entertained while you wait means she's doing well.
Wanna stand up again?
Okay. So we're gonna start putting some orders in, like for the MIBG, for example. So you might get a call from the schedulers to schedule that. But otherwise, we'll kind of take it one step at a time and hopefully get you guys home tomorrow.
Can you please word out the MIGB?
MIBG, what it stands for?
Oh my goodness
Ooh,
gracious.
wait, let me look at.
It's,
Oh.
it's a word about this long.
Yeah. Let me get it.
Well,
so I can
it's
write
not
it down.
necessary, but
Putting you on the spot. I was
We both failed the quiz. Okay.
It's Iodo something something.
NYBG. Even when you type it
It's
out.
iodine with a little radiation on it.
Yeah. Acronym.
That's the part that
Oh, so you
Okay.
can, like,
So
trace it, you
meta
can see it through the body.
iodobenzoguanidine.
really very helpful that
NYBG.
only neuroblastoma cells take that up.
we'll look it up on Google.
good.
If
Oh,
you type up-
Yeah.
So like where they like when you swallow stuff for like heart attack stuff, and they can see like the
Yeah, I
stuff
think
line up in your
so. I don't
veins
know
and
as much
stuff.
about heart attacks these days because I haven't taken care of an adult in a very, very
yeah.
long time. But yeah, I think it's the same thing where like it goes to the part of the body that you're
Yeah.
concerned about, and then it kind of glows. It's kind of like a PET CT, except it's really specific to
Oh, okay.
neuroblastoma, so it's really useful.
Oh, you keep biting.
She was trying to eat my hand before. You can hear Dad's hand. That's okay.
I'm just a mattress these days.
Yeah.
Started to
Very good one. Okay. Any other questions that we didn't answer yet?
Yeah, so I guess on the short term we're just doing this MRI, then probably going home tomorrow.
Yeah. I will say we probably won't get a read on the MRI until tomorrow because it's happening late.
Yeah.
They'll call me if they see something they're really worried about,
Yeah.
but otherwise we'll get a read in the morning.
Yeah, and then after that we just wait for probably do the MIBG and the bone marrow stuff and put the port in and then start chemotherapy in like 2 to 3 weeks unless something happens.
Yeah. And we'll work on trying to do the fewest anesthesia as we can, but there will probably be more than one. It's just
Yeah,
very hard to get everything done.
there's no short amount of
Yeah, I think to get everything coordinated, it would take too long to find that day where everyone's all available. So instead we do a couple, but at least give you a little bit of a break from being on an empty stomach, okay? And usually when it's outpatient, it's a lot more rigid of a schedule because emergencies don't bump you in the same way they do when you're
Get people who are, like,
inpatient.
traveling to get to the
Yeah, it's just sort of like it's like its own little world, even though
Yeah.
it's done in the same scanner. So you have a little more control as an outpatient about your time, which is good. Well, you're being very good about it.
Yeah, I'm impressed.
Do you know the name of the chemotherapy drug?
There would likely be multiple different chemotherapy drugs, and so once we decide which regimen, it'll be able to give you a list and a printout of all the drugs we would use and
Okay.
kind of, specific things to look out for and side effects for each.
Excellent.
Yeah.
Yeah. We obviously have to give you guys a lot of info before we get your consent or your permission to start treatment, so you'll know everything about all the drugs that we're using and expected side effects.
Okay.
I know you met our social workers yesterday. Once, I updated them that we got the diagnosis, so it just starts kind of that people coming in and kind of going through whatever resources make sense for you guys.
Well, I'm sorry Fernanda couldn't be here, but I'm glad we got a video so we can send her and she can hear all this, and then if she comes up with questions too, we are obviously happy to answer anything that
Okay.
comes up.
And I would suggest if they don't think about it, ask them to videotape because you don't hear everything when you're getting bad news. You're so overwhelmed. And so make sure, Lee, I'll tell you too, get it so that, because
Yeah, if you have to remember.
Yeah. And we're happy to, once we have more of a plan, we're happy to put things in writing for you
Yeah,
too
of
about
course.
what's going to happen when. And of course, when chemo starts, everything will be printed out for you about the meds that we're using.
awesome.
Yeah.
Okay.
Okay. Well, I hope you guys get to the scanner soon.
Yeah, thanks
And
for
then
all
we
the
can have
info.
some good FOOD. Yeah, a late lunch. Okay. We're going to take really good care of her, you guys.
I know you will.
Okay, that's our big takeaway.
Yeah.
Okay, over you. It's a wheelchair.
Thanks for
You're
stopping
right,
by.
okay.
and telling us
Thank
guys.
you.
We'll see you.